Good afternoon. My name is Captain Eleni Anagnastiadis from FDA's Office of External Affairs, and I will be serving as the moderator for today's stakeholder call, which will focus on COVID-19 drug products. We are so fortunate to have three esteemed leaders from HHS and FDA joining us today. From FDA, we have Dr. Patrizia Cavazzoni, Director of the Center for Drug Evaluation and Research, also known as CDER, and Dr. John Farley, Director of the Office of Infectious Diseases in CDER, FDA, who will share information on the three recently authorized COVID-19 drug products. Then we will transition to Dr. Jason Roos, the new COO of the HHS Coordination Operations and Response Element, or HCOR, which resides in the Assistant Secretary for Preparedness and Response, also known as ASPR, who oversees the allocation and distribution of all United States government-purchased COVID-19 drug products. A few housekeeping items before we get started. Please take a moment to ensure that you are muted when you're not speaking. This call is being recorded and will be posted on FDA's YouTube channel at a later date. With that, I will turn the call over to Dr. Cavazzoni.
Let me start by thanking you for joining us today and for your commitment and efforts to advance public health and healthcare through these unprecedented times. Today's call would focus on three recently authorized drug products for COVID-19. The first one is Evusheld, Paxlovid, and Molnupiravir. The first one was authorized for, is a monoclonal antibody that was authorized for prevention of COVID-19. And the other two authorizations were for antivirals that are used for treatment of mild to moderate COVID-19 to be used in certain instances and in certain populations. Evusheld is a long-acting monoclonal antibody that was authorized for the pre-exposure prophylaxis, meaning prevention of COVID-19 in certain adults and pediatric individuals, 12 years of age and older, weighing at least 40 kilograms or about 88 pounds. Paxlovid, an antiviral, was authorized for the treatment of mild to moderate COVID-19 in adults and pediatric patients, 12 years of age or older, weighing at least 40 kilograms or about 88 pounds, with positive results of I'm having some audio problems. With positive results of direct COVID-19 testing, and who are at high risk for progression to severe COVID-19, including hospitalization or death. Molnupiravir is an antiviral which was authorized for the treatment of mild to moderate COVID-19 in adults with positive results of direct SARS-CoV-2 viral testing, and who are at high risk for progression to severe COVID-19, including hospitalizations or death, and for whom alternative COVID-19 treatment options authorized by the FDA are not accessible or clinically appropriate. So last month's actions are important steps towards the fight against COVID-19 and demonstrate the agency's commitment to expanding the arsenal of treatment options available to the public. And this is becoming even more important as new variants of the virus continue to emerge. We recognize that many have been waiting for at-home treatment options that might help to alleviate the burden on our nation's healthcare system. Currently available FDA authorized therapeutics require IV infusions and are limited to use in hospitals and in infusion clinics, prior obviously to the authorization of the two oral antivirals. The oral antiviral medications that were authorized a few weeks ago are designed to stop the virus from replicating and can be prescribed for at-home use by the patient populations and under the conditions for which they're authorized. It is important to note that these antivirals are not authorized for the pre-exposure or post-exposure prevention of COVID-19 or to treat patients who are already hospitalized with severe or critical COVID-19. We also want to remind you that these products are not a substitute for getting vaccinated. The FDA has approved one vaccine and authorized others to prevent COVID-19 and other serious clinical outcomes associated with COVID-19 infections, including hospitalizations and death. The FDA strongly urges the public to get vaccinated and to receive a booster if eligible. In remaining true to our commitment to transparency, in addition to the press releases and other materials that we have issued, the data that the FDA evaluated to come to these decisions are posted on the FDA website. I'd like to close by thanking the FDA's career staff that is made up of large teams comprised of physicians, biologists, chemists, epidemiologists, statisticians, and other professionals who have been working around the clock over the past few months to evaluate the data and the information in these emergency use authorization requests. We know that this pandemic continues to be dynamic and evolving, with new research and data becoming available every day. When supported by the science and the data, we are committed to making additional drug products available while continuing to study their safety and efficacy. Now I'd like to turn it over to Dr. Farley, Director of the Office of Infectious Diseases, for his remarks.
Thank you, Dr. Cavazzoni, and it's a pleasure to be here with all of you today. So as Dr. Cavazzoni mentioned, about a month ago, we issued an emergency use authorization, or EUA, for Evusheld, which is texagevimab co-packaged with calgavimab and administered together for the pre-exposure prophylaxis or prevention of COVID-19 in certain adults and pediatric individuals being 12 years of age and older who weigh at least 40 kilograms, which is about 88 pounds. So this product is only authorized for those individuals who are not currently infected with the SARS-CoV-2 virus and who have not recently been exposed to an individual infected with SARS-CoV-2. The authorization also requires that individuals either have moderate to severely compromised immune systems due to a medical condition or due to taking immunosuppressive medications or treatments, and they may not mount an adequate immune response to COVID-19 vaccination, or they have a history of severe adverse reactions to a COVID-19 vaccine and are a component of those vaccines, such that vaccination with an available COVID-19 vaccine according to the approved or authorized schedule is not recommended. One dose of Evusheld administered as 2 separate consecutive intramuscular injections, that's 1 injection per monoclonal antibody given in immediate succession, may be effective for the pre-exposure prevention for 6 months. Evusheld is not authorized for individuals for the treatment of COVID-19 or for post-exposure prevention of COVID-19. Patients should talk with their healthcare providers to determine whether Evusheld is an appropriate pre-exposure prevention option for them. As Dr. Cavazzoni noted, we're keenly aware of the public's interest in oral COVID-19 treatment options. I'd like to share more information about the actions the FDA has recently taken. We issued an EUA for the first oral antiviral to treat mild to moderate COVID-19, Paxlovid. Paxlovid is authorized for use in adults and pediatric patients, specifically those who are 12 years of age and older and weigh at least 40 kilograms, and who are at high risk for progression to severe COVID-19, including hospitalization or death. And after taking into account the informative discussion with our advisory committee of external experts in November, we also issued an EUA for another oral antiviral to treat mild to moderate COVID-19, molnupiravir. Molnupiravir is authorized for use in adults with positive results of direct SARS-CoV-2 viral testing and who are at high risk for progression to severe COVID-19, including hospitalization or death, and for whom alternative COVID-19 treatment options authorized by the FDA are not accessible or clinically appropriate. Both antiviral drugs are only available by prescription, and treatment should be initiated as soon as possible after a COVID-19 diagnosis and within 5 days of symptom onset. Both antiviral drugs have potential side effects and unique safety considerations for certain populations. Patients should consult with their healthcare provider to carefully consider the known and potential risks and benefits and determine if either treatment is right for them. For all the authorizations, the FDA thoroughly examined data submitted by the sponsors on the safety and efficacy of each product to ensure that they each met the agency's standards for emergency use authorization. Complete information about the data evaluated for each product, as well as limitations of use, recommended patient populations, safety considerations, and more can be found on FDA's website. Under the EUAs, fact sheets must provide important information about using these products as authorized and must be made available to healthcare providers and to patients and caregivers. These fact sheets include dosing instructions, potential side effects, and drug interactions. At the FDA, we're committed to making important regulatory decisions based on the most up-to-date science and data available to us, and these authorizations are no exception. With science guiding our decision-making, the available safety and efficacy data support the authorization of these products because their known and potential benefits outweigh their known and potential risks when the drug products are each used consistent with the terms and conditions of their respective authorizations. So now I'd like to turn the call over to Dr. Roos.
Thank you, Doctors Cavazzoni and Farley, and thanks to all of you for joining today's call. As Elenia mentioned, I recently joined the HHS family as the Chief Operating Officer of what's now known as the HHS Coordination, Operations, and Response Element, or HCOR. Previously, this entity was known as Operation Warp Speed and later as the Countermeasures Acceleration Group. And while I'm just 2 weeks into my role as COO of HCOR, I've been part of the pandemic response effort since the start. Prior to joining HHS, I led the Department of Defense's Joint Program Executive Office for Chemical, Biological, Radiological, and Nuclear Defense. That organization was and remains a critical HHS partner in the development, procurement, and distribution of COVID-19 vaccines and therapeutics. Today, I want to take this opportunity to talk generally about how we are managing the allocation and distribution of the therapeutic products, and then focus specifically on Evusheld, Paxlovid, and Molnupiravir. When it comes to COVID-19 therapeutics, we have approached it like filling a medicine cabinet. We're not relying on one type or one brand or one treatment. We ensure that we would invest in and buy a broad variety across monoclonal antibodies, pre-exposure prevention therapies, and oral antiviral pills. Right now, there are 6 products that have received emergency use authorization from the FDA that HHS purchased and is making available to health departments at no cost. The reality is, however, that the supply of these products is not enough to meet demand, and that is why HHS oversees product distribution to ensure these therapeutics reach communities across the country in a fair and equitable manner and on a consistent basis. We couldn't do this without the help of our state and territorial health department partners. Each week, HHS determines how much of each therapeutic product state and territorial health departments receive. Those health departments, in turn, determine where the product actually goes across their jurisdictions. For the monoclonal antibody therapeutics of Lilly, Regeneron, and GSK, HHS determines how much product health departments are allocated using a disease-based methodology that takes into account COVID-related hospitalizations and new COVID case counts within a jurisdiction. For Evusheld and the oral antiviral products of Paxlovid and Molnupiravir, HHS determines these allocations on a pro rata basis using the adult population within jurisdictions. All of the monoclonal antibody products are allocated on a weekly basis, and the oral antivirals are allocated every 2 weeks. Equity is at the core of all decisions we make relative to allocation of these drugs, and we encourage state and territorial health departments to focus on equitable access in their jurisdictional planning as well. To further support this effort, HHS is identifying about 200 Health Resources and Services Administration, or HRSA funded, health centers that will receive direct allocations of the oral antiviral drugs. These allocations are separate from and on top of what we allocate to health departments. I know that the focus of today's call is on the monoclonal antibody Evusheld and the oral antiviral products of Paxlovid and Molnupiravir. So I'd like to give you an idea of the amounts of these products we project to allocate to health departments for the remainder of January. I do want to highlight that the COVID-19 environment remains dynamic and that these are projected allocation numbers that may change. For Evusheld from AstraZeneca, we plan to allocate about 300,000 courses over the remainder of this month. For Paxlovid from Pfizer, we project an allocation of about 200,000 courses across the rest of January. And for Molnupiravir from Merck, we plan to allocate about 800,000 courses. We are very transparent regarding this process, and I encourage you to visit phe.gov/COVID Therapeutics to learn more about the allocation and distribution of these drugs, as well as view an up-to-date dashboard on how much product has been allocated to each jurisdiction. This dashboard is updated each Monday afternoon. So I provided a very high-level overview of how we're managing the allocation and distribution of COVID therapeutic products. I thank my FDA partners once again for the opportunity to join this call, and I welcome any questions you may have during the Q&A session. Back over to you, Elenia.
Thank you so much. Thank you, Drs. Cavazzoni, Farley, and Roos. At this time, we will begin the question and answer portion of the call. When asking a question, please turn on your camera, state your name and affiliation. If you prefer, you may enter your questions into the chat box at the bottom of your Zoom screen. Also, please limit yourself to one question and one follow-up pertaining to the 3 EUA announcements mentioned on the call so that we have an opportunity to get to as many questions as possible. I'd like to begin with a few questions that we have received via email. The first question is for Dr. John Farley. With Omicron now the dominant variant in the United States, it feels like the options have changed for the treatment of patients with mild to moderate COVID-19 at high risk for disease progression. What options are being recommended?
Yeah, thanks very much for that question. And you're absolutely right. The Omicron variant of concern is now the dominant variant in the United States. And this variant has numerous mutations in the spike protein and is expected to have markedly reduced susceptibility to bamlanivimab plus etesevimab and casirivimab plus imdevimab, which has the trade name REGEN-COV. So at this time, among the monoclonal antibody products, sotrovimab is the only available product that is expected to have activity against the Omicron variant of concern. Now, FDA and all healthcare providers look to the NIH and the IDSA COVID-19 treatment guideline panels to provide recommendations for clinical care of patients using approved or authorized drug products. And recently, because of the dominance of the Omicron variant in the US, the NIH guidelines panel provided recommendations for therapeutic treatment options for non-hospitalized patients with mild to moderate COVID-19 who are at high risk of progressing to severe disease. And these therapeutic options include Paxlovid, sotrovimab, remdesivir, and molnupiravir. We haven't mentioned remdesivir during this call so far, but remdesivir is an approved drug. And recently, Gilead announced positive results from a trial testing a daily administration of remdesivir for 3 days in high-risk outpatients, and also announced that this data had been submitted to the FDA. While we have remdesivir as an approved drug for inpatient use, FDA is, of course, expediting the review of these data concerning outpatient use. FDA is also aware that there are limited options for children and is working very hard to address that. Thanks.
Dr. Roos, as you highlighted, ASPR's HCOR is responsible for overseeing the distribution of COVID-19 therapeutics to state and territorial health departments. What type of guidance or assistance is HCOR providing to health departments to assist with their planning and to help promote equitable access?
Lania, thank you for that question. So we have been partnering with states since May of 2020 in the context of remdesivir at the time to help get COVID-19 therapeutics where they are needed most. ASPR has regional emergency coordinators on the ground across the country who have been working hand in hand with health officials to develop jurisdictional distribution plans. This has included offering technical assistance and clarification of guidance. Relative to the oral antiviral products, Paxlovid and Molnupiravir, we established a forum for our vaccine pharmacy partners to engage with state and territorial health departments and explore partnerships for dispensing of those products. The HHS, National Institutes of Health, provides treatment guidelines relative to the therapeutic products that health departments can use to assist with determining where the product should go in their respective areas to help those in greatest need. Additionally, we continue to host weekly webinars with state and territorial health officials and their pharmacy partners to assist with refining jurisdictional allocation and dispensing plans. These webinars are in addition to the weekly update calls we host with health officials to provide general updates on COVID therapeutics and to answer any questions they may have. Altogether, we're committed to doing what we can to assist the states throughout this process.
Thank you for that response. Our next question is from Lisa Litorno, and her question is, what is the expectation for sharing and or reviewing the FDA EUA patient family fact sheet with patients for the new authorized medicines? i.e., is it enough for a pharmacy to hand out that info sheet, or is there an expectation or requirement for someone to review it with them?
Sure, so I can start with that question and welcome any of my FDA colleagues. So the question concerns the patient and caregiver fact sheet. And for each of the EUA products, that fact sheet is available online through a QR code, which is available on the packaging, for example. I think it's an excellent tool to share with patients and to walk through the benefits and risks of the product. Our anticipation is that that would happen at the prescriber level for sure. And certainly is a part of good pharmacy practice to share with patients when the product is dispensed. For Molnupiravir, it's a superb tool, and it's redone similar to an FDA med guide, really useful for patient counseling. And for Molnupiravir, providing that, and this is a prescriber duty, to the patient when they're counseled, as well as documenting that counseling is a requirement of the EUA.
Thank you so much, John, Dr. Farley. Now I'm going to go to Michael Ganio. It looks like you have your hand raised. Could you please unmute your mic? And we may need our AV support to help him do that. And pose your question, please. Thank you.
Can you hear me?
Yes.
Great. Thank you for taking the question. I'm Mike Gagno with the American Society of Health System Pharmacists. And I'd really like to appeal to FDA to please consider developing or releasing some recommendations for nirmatrelvir tablets that are removed from the Paxlovid packaging in patients who require renal adjustment. Some pharmacies would have the ability to take those additional tablets and immediately repackage them into what would be considered USP Chapter 671 Class A packaging to prevent moisture exposure, light exposure and really could help extend the use of some of those tablets rather than wasting them. The pharmacies that have this ability would also have tablets of ritonavir available, and therefore could stretch that supply that is very thin right now a little bit further. These would be scientifically supported recommendations. I think working with USP, we'd be happy to work with you. Pfizer should be able to provide some sort of stability for that outside of the Class A packaging that the original containers are in. So I just want to appeal to FDA to work with Pfizer, work with USP to help us extend that supply further.
Yeah, no, thanks for that, and thanks to ASHP, who's been an amazing partner for drug shortages with FDA for many years. So we hear that. We'll take that back. I'm not an expert on repackaging. I don't think we have those experts on this call, but we really appreciate the feedback.
Thank you. So we received a question, what is the CDC site to see the distribution of prescription medicine? So we'll see if one of our colleagues here at FDA or ASPR maybe can get us the link to where folks can find the distribution of the prescriptions, I think that were mentioned earlier. So we see your question and we'll be working on that. The next question comes from Nancy Foster. Are there options for those communities that still have Delta as their dominant variant to get more of the therapeutics that are not effective against Omicron variant?
I can take that one. So, so we are still providing the Lilly and Regeneron monoclonal antibody products to the jurisdictions. Under the caveat that their use should be very much considered in light of the prevalence of Omicron and understanding that their lack of effectiveness against Omicron. So as of today, we are still allocating that product to jurisdictions, and I know jurisdictions also have inventory of those two products. However, I will caveat that we are continuously evaluating the allocation process based on the prevalence in the United States and its territories.
Thank you, Dr. Roos. Our next question comes from Nirav Shah, and I'm not sure if this is going to be a question our principals can answer, but the question is, has Gilead provided a sense of how much remdesivir is available for use? And this question comes from the State of Maine CDC.
I'll take that. So the numbers are still working with Gilead on the specific numbers and that are available, but the supply for remdesivir for both inpatient and outpatient treatment is much less constrained than we've seen with Paxlovid, for example. So there is an adequate supply that the company has articulated and communicated to the U.S. government.
Thank you, Dr. Roos. Our next question comes from Isaac Benowitz. I have heard concerns from providers about patients getting Paxlovid, even if they do not meet the FDA EUA criteria. How can health departments help to ensure that these drugs are only prescribed in accordance with the FDA EUA criteria?
Yeah, so I can make a few comments. I think we've been very clear in healthcare provider fact sheets who the appropriate patients are for Paxlovid prescriptions, as well as prescription of the other authorized products. I think also the guidelines panel have opined on making difficult decisions in a setting in which we simply do not have as much availability of all the products as we would like. So I would certainly hope that my clinical colleagues would make appropriate decisions. And I think that's about the only comment I can make on this one.
Thank you. So there's a question here. Let me just see. Can you share how the HRSA sites were selected, the number of sites, and the location? I'm
Yeah, this is
assuming
Jason.
the distribution.
That's for me. I'm sure that's for me. Yeah. So, we each of the sites were chosen in coordination with HRSA to really try and target and ensure that the product was going to be able to get to underserved populations and not overlap with where the product was already targeted for in each of the jurisdictions. I'll have to take back. I don't have a handy place right now to point you to as far as the various HRSA locations, but that's something that we'll take back as an action.
Oops, I'm sorry, I was on mute. This next question comes from Lisa Letourneau. Are there any updates on the HHS Therapeutics Locator tool? This looks like a great tool, but as of last week, it wasn't clear if it was functional yet. And there is that link in the chat box. And I'm not sure if you could speak to that, Dr. Roos.
Yes. So the initial version is I assume it's the one that you've put up there in the link, and we're continuing to work with the development team to refine that product to ensure that it as best as possible accurately reflects the product that is available, so that healthcare providers and patients have some visibility on where to find those products.
Excellent, thank you. Dr. Farley, would you be able to do a quick review of which products work for Omicron versus Delta?
Sure. So I think in terms of products that are appropriate to use in a setting in which you have reason to believe that the patient has an infected with an Omicron variant, and I think incident infections in the United States these days, that's a very reasonable assumption for nearly any patient, unless you have local data that is not consistent with that view. So as I mentioned, we do have 4 products that retain activity in the presence of an Omicron infection, and they include Paxlovid, sotrovimab, remdesivir, and molnupiravir.
Thank you so much. And thank you to Ms. Waters. She has provided in the chat box the link to the HRSA-funded health centers that will receive direct allocations of oral antivirals. So thank you so much for that, Ms. Waters. It looks like we have a hand up, so I will now, if you can unmute your mic, Scott Bergman. Thank you.
Hi, this is Scott Bergman. I'm the pharmacy coordinator for antimicrobial stewardship at Nebraska Medicine and president for the Society of Infectious Diseases Pharmacists. One of the questions we've been having in our health system is about outpatient reimbursement for remdesivir. And then as a second part of that question, the oral antivirals, once they become more widely available at pharmacies, will there be reimbursement, and is there a process for that through third parties as well as government payers?
Yeah, I can make a few comments. I actually don't think we have reimbursement experts on the phone, and that can be a complicated topic. What I can tell you in terms of remdesivir outpatient use is that Gilead's application that is under review would be to move that particular outpatient use of the product into a labeled use. So it would be an approved use of the product, which I think is always one potential barrier to reimbursement. But I think that's about all I could comment on, unless others have any comments they'd like to share.
Yeah, Dr. Farley, I would just add and agree with everything you said, and just add that the CMS provided Gilead with a J code for the outpatient use of remdesivir on the 7th. That's posted on their website.
Okay, great, thank you. And the oral antivirals, are they still in the works as far as adjudication through third-party insurance and Medicare plans?
Yes, that's my understanding.
Thanks.
It looks like we have a question from Sarah Barkley in Ohio. How frequently is the Therapeutics Locator being updated?
So as we are collecting data in terms of orders and shipping, we're updating the Therapeutics Finder. So it's a minimum on a weekly basis, but I'd have to confirm if there's a greater frequency with which we're updating it.
And Dr. add to that as well that the database will be updated on a daily basis, and the information will be relative to what a location has as reported within the previous 24 hours. And the team just confirmed that for me just now as you were speaking.
Thanks, Cicely.
Excellent, thank you. And for that particular question and response. I think that is it. It looks like we have gone through all of our questions, both in the chat box and in the hands that have been raised. I would like to give Dr. Cavazzoni, if she has any closing remarks, if she is still with us, that she'd like to provide an opportunity to provide any closing remarks.
Yes, thank you. So thank you again for joining us today and for the very good discussion and the very thoughtful questions. Obviously, this massive public health effort is very much of a team effort. And so as U.S. government agencies, we are most effective when we can partner with all the stakeholders in the healthcare delivery and public health sphere. And so this is an example of sort of the dialogue that can be very helpful in terms of, to make sure that we are all moving in the same direction. We are going to come back to you with the questions that we could not address, or at least come back to you with as much as we can share. And obviously, the situation is very dynamic and evolving, and so we will do our utmost best to continue to update the public health and healthcare system communities as new information emerges on therapeutics, distribution, and so on. So thank you again, and we look forward to future interactions.
Thank you, Dr. Cavazzoni. So this concludes today's stakeholder call. A recording of today's call will be posted on the FDA's YouTube page in the next few days. If you have follow-up questions, please contact the FDA Stakeholder Engagement staff at fdastakeholderengagement@fda.hhs.gov. Thank you.